Susan Cole from Phoenix Health Movement.
And I'm Denis Onyango from Africa Advocacy Foundation.
And welcome to episode 4 of Positive Health, the monthly broadcast series focused on HIV and the pressing issues affecting Black communities. We're absolutely thrilled to be joined by two phenomenal guests. This episode, we have Rebecca Mbewe, who has over 25 years of personal and professional experience of HIV. She's a co-director of the 4M Network of Mentor Mothers, research assistant with the SHARE Collaborative at Queen Mary University London, and one of the co-authors of Our Stories Told by Us, celebrating the African contribution to the UK HIV response. A really brilliant book.
Thank you. And we have Dr. Rageshri Dhairyawan, who is a consultant in sexual health and HIV medicine at Barts Health NHS Trust, and also Deputy Director of the SHARE Collaborative. Her work focuses on improving health equity. She is the author of a multi-award-winning book, Unheard, The Medical Practice of Silencing.
Ooh, another book I would highly recommend. And two people from the SHARE Collaborative, they're taking over this week, aren't they?
Amazing. It's so lucky to have them.
There's been a lot going on in HIV this summer. Something that's really struck me is the London HIV Prevention Programme. They've recently launched a landmark report looking at HIV and Black communities. It really shows significant inequalities affecting people from Black communities around HIV. We're more likely to be diagnosed late, we're disproportionately affected, we face barriers to testing and access to PrEP. We've seen lots of reports that talk about the problems that Black communities face around HIV, but what's different about this report is that it talks about the absolute brilliance of the HIV community, but also it highlights some of the actions and changes and solutions that we need now. And one of the things that they've suggested is the importance of integrating anti-racism in terms of the health system, thinking about really involving the community at every aspect of work and having more community-led interventions, and also actually thinking about some novel ways of getting information across. And one thing that I went to that was absolutely fabulous that Do It London did was a pop-up nail bar that was actually also doing HIV tests at the same time and having these conversations. And we know that Black women in particular face barriers to testing, and we don't think that HIV is something that affects us. So actually having tests and conversations in these types of areas are really helpful. And I'm actually going to be talking about this on BBC London News in the radio at 7 in the morning, and then on TV later on in the week. So look out for that. So yes, so let us bring on our first guest. Let's come on with Rebecca. Hello, Rebecca. Wonderful to have you on.
Hello, Rebecca.
Hi, Susan. Hi, Dennis. Thank you. It's such a pleasure to be asked to come on.
It's fantastic to have you. And I was talking a little bit about Black women and HIV and the fact that we are disproportionately affected. But I'd like to start off by thinking about older Black women with HIV. What do you think some of the challenges are as women grow older with HIV?
Thank you, Susan. I think the challenges that women growing older with HIV face are many. I would like to sort of put them under these three overarching kind of categories. So one of the challenges they face the most is physical. So stuff around menopausal issues, so health issues, physical issues, increased rates of osteoporosis, weakening of the bones, cardiovascular risk as well, which if it's untreated can lead to angina and heart attacks. Those are mainly the physical symptoms. I mean, there are many. Wondering whether it's actually HIV related or whether it's, menopausal related is also a big concern. Then we look at also the mental and emotional health and well-being, and a lot of depression, a lot of anxiety coming from a number of issues. And one thing I would like to emphasize is probably stigma being one of the main issues, which means a lot of women can then disengage from care. And this can obviously then lead to challenges with adherence. And you can see where I'm going with this. Then when you have problems with adherence, that means that you get more poorly, and then the cycle just continues. So that's also a big challenge. Then we have the psychosocial issues. People worry about their securities in the older years. I think there was a time when women were being diagnosed and, we either had to stop work or we just weren't able to get into work, so you didn't get the opportunity to build up a pension, and all those kinds of things. So that's a great concern for a lot of older women. The other thing alongside that is also we worry about what happens if I had to end up in care. What kinds of issues will I face there? And again, that brings us back to the stigma that we worry about how we're being treated by healthcare professionals. So I'll leave it there for now.
Thank you.
Well, thank you for that detailed response, Rebecca. And I know, you've been working in this space for a long time. You're a long-term advocate, and you've been working mainly on women's issues. I just wanted to ask what you think the system should do to be able to address the needs of women who are living with HIV, but also dealing with a lot of intersecting issues. And we know by that I mean, we have women who are parents, who have children, sometimes have no recourse to public funds, maybe experiencing domestic violence. So the whole intersection of gender, ethnicity, race, how and with HIV, how do you think we could address this? What needs to be done to increase support for them?
I think to begin with, it's important to say that within the HIV sector, we're very much used to dealing with these kinds of things and know the right approach. So maybe it's taking the best learned sort of practice that we've developed within the HIV sector and then extend that to outside, whether it's social services, social care, all the general, and that's to begin with, create a much better awareness of HIV and the issues that it brings, so that we can learn from that. And I think the other thing it's important when we're making or developing these services is to make sure that the people who are affected by HIV and in the way that they're affected by HIV be involved in developing all of these services. Ask the people what they want, how they want it. And then we can reach sort of a middle ground and a consensus in terms of how we can solve these issues.
Absolutely. That's such an important point. And I think so often for so long, we've seen people with HIV just not involved in our care, and if we are asked to be involved, it's brought in right at the very end as a tick box exercise. So you're making some really important points there, and we've seen really fantastic progress in HIV treatment recently, like long-acting treatment, but there's concerns that communities aren't all benefiting equally. What do you think we can do about that?
I mean, it's amazing when you think about how far we've gone, how far we've come with treatment. So, and you're right, not all communities are benefiting from these innovations, such as long-acting treatment, whether it's injectables or anything else. What I believe we could do to rectify this is to make sure we get involved in research. So we need a lot more people of color, Black women, women in general, including transgender women, to really get stuck in and involved in research. I mean, one such study that I'm aware of is the Ask Us study, which I'm involved in. It's something being developed. Yeah, go on.
Yes, I think we can pull up something about this and you can talk about it.
Thank
Rebecca.
you. So the Ask Us study is a Europe-wide study that is seeking to hear from people living with HIV and who are on HIV treatment, to hear their experiences about their medical consultations and any new HIV treatments that they talk about with their consultants. The experiences that they have are hugely helpful in helping to shape and to improve the HIV treatment access across Europe. I mean, as you can see, the QR code is on the screen right now, so please share it as widely as possible. Thank you.
Fantastic. Thank you very much, Rebecca. That looks like an absolutely brilliant piece of research. And I love it that it's Europe-wide. Is that the case?
Yes, it is. I think it's across 17 countries in Europe. Yeah.
Brilliant.
So.
I just wanted to ask again, Rebecca, we have been seeing a lot in the media, and especially right now in the UK, a lot of demonizing in the media of migrants. What do you think what effect do you think this is having on the health and well-being of people from migrant communities?
It's really sad issue to be talking about, particularly in this day and age, isn't it? I feel that migrants being portrayed, being demonized in the media has a very indirect and direct impact on their health and well-being. And some of the major, there are lots of things lots of ways that they get impacted. But again, I'll just narrow it down to 3. So it has a huge mental health impact. So this constant exposure to negative stereotypes, being framed as a burden or as a threat, it just increases stress and anxiety and depression. And then this, of course, then has, an impact on people's physical health, which means then they avoid accessing healthcare because they don't want to be mistreated, they don't want to be judged, or being reported to migration authorities. And we know that that's what happens sometimes. And then obviously then that has a domino effect. And this impacts your social and well-being as a migrant. So, being demonized, the demonization fosters hostile environments, as we can see. It makes it harder for migrants to feel safe in the communities that they've settled in. And then there's an impact economically. If you think of the cost, eventually what happens is if you don't access healthcare, you just get really, really ill and then end up in emergency care. And then you have, there's hospital beds that are being taken up and all of that. So what would you rather? That people access the healthcare properly, or they end up in, needing much, much wider care. So in short, demonization of migrants doesn't just harm public perception, it creates real, lasting and immeasurable health inequalities amongst the migrant communities.
Absolutely. I couldn't agree more. And I'd just like to end with one quick question for you, Rebecca. What advice would you give to a woman living with HIV who may be juggling so many different issues in their lives?
I think the short and simple answer to that, Susan, is to seek support from relevant organizations. I know funding is a big issue, but there are still services out there. So seek support from the right organizations for the right issue. You will find that you will get support and be able to then prioritize what's really important. And very slowly you will get to a point where it doesn't seem so overwhelming anymore.
Fantastic. Thank you so much, Rebecca.
My absolute pleasure.
And if anyone wants to get our stories told by us, where can they get it?
Thank you for the shout out. You can get it on Amazon. You can get it on our website, Our Stories Told by Us. So please do go ahead and get yourself a copy.
Fantastic. Thanks, Rebecca. Bye-bye.
Thank you. Bye.
Denis, I know that you've been really busy speaking at a conference in Portugal recently about migration and health. Can you tell us a little bit about the research you've been doing and what you highlighted in Portugal?
Yeah, so this was a very fantastic conference on migration, ethnicity, race, and health with a lot of researchers from around the globe. It was really very good to have that focus on migration. And so we have a research that we've been conducting on My Health Europe, and we presented a few papers, but the abstract on factors associated with HIV amongst migrant men who have sex with men was chosen. So this was my presentation. And as you know, in Europe, around 48% of people who are diagnosed with HIV are migrants. So this particular one was focusing on the work we've done over the past 2 years, testing migrants, of which men who have sex with men were around 74 who were diagnosed out of 113 that were tested. And this was 17.9% as compared to the general migrant population we tested. 4%. So yeah, that was like really, really concerning. And as you know, the narrative is always that people bring HIV to Europe, but we know very well that over 63% acquire HIV when they've arrived, and this is high, like around 72% for migrant men who have sex with men. So our key highlights on the presentation of the research was just about the geographic origins. A lot of them were coming from South America, 64%. We were looking at barriers and vulnerabilities, where we discovered that many are involved in transactional sex work. And of course, PrEP usage was very, very low at 4%, despite awareness being at 43%. So this were the key highlights. And the message really was that the HIV is high amongst men who have sex with men who are migrants, and we need interventions that can address the gaps that we see in PrEP access, for example, and other interventions.
Fantastic. That sounds really important, and absolutely we do need to get that access sorted out and end these inequalities affecting migrants. But let's bring on our next guest, Dr. Rageshri Dhairyawan.
Hello, hi, lovely to see you both.
Hi Rageshri, lovely to have you on. Now, everyone I speak to absolutely loves Unheard. So your truly groundbreaking book, and it really resonates with people of color all around the world who regularly report just not being listened to. Can you tell us about some of the issues you explore in the book?
Yeah, absolutely. So I wrote the book because I had my own experience of being not listened to on the ward as a patient about 12 years ago. So woman of colour came in with really excruciating pain, asked for pain relief and was dismissed and disbelieved. And at the time, I was really struck by the fact that I felt really unable to advocate for myself because I didn't want to be seen as being a nuisance. And when I left the ward, I also didn't make a complaint. And I thought, if this could happen to me, if I can be silenced, and I was a new NHS consultant at the time, I knew how everything worked in the NHS, what on earth happens to everyone else? So for me, it really made me understand that, people always say all the time that if you want better care better healthcare, you really need to shout for better care. But it's really hard to speak up and shout when you're at your most vulnerable. So it's really up to us in healthcare to listen better. And that's why I wanted to write the book. And I really wanted to understand what makes it hard for doctors like me to listen. So the book really explores kind of power hierarchies in medicine, looking at how we can rebalance those power hierarchies. And I look at how this silencing and need for better listening happens at all levels. So in the consultation room, it affects patient safety, but also happens in the medical workforce. It happens in research. And when it happens in research, it means that we get knowledge gaps. We don't have the right research done about silenced communities like Black communities. It happens at a global health level, and it happens in our evidence production and in policy. So I really wanted to explore how this silencing happens, and more importantly, what can we do about it?
Fantastic, thank you. And it's made such a difference and really helps people when they've read it. So thank you.
Thank you.
Thanks, Dr. Rageshri. What advice would you give someone living with HIV who feel that they're being silenced?
So I think it's really important to know, first of all, that you're not alone. This is something that is really widespread, and also it's not your fault. So I think people sometimes worry that it's down to them that this has happened, but it's not at all. This is a widespread, and it's a really historical issue. It's kind of ingrained in medicine, which I explore. But, you know, there's a few things you can do. I think if you have a trusted friend who you feel, you know, able to bring to your appointment with you, that can be really helpful, because they can be there as kind of, you know, psychological support. But they can also help remind you of what you wanted to ask your doctor about. They can stick up for you if you need to. And also they can help you remember what was said in the appointment. I think it's also really important to come prepared. So think about, you know, what do I want from this consultation? What do I want out of my doctor? And don't be afraid to bring a list. I think people always really worry, but actually, you know, we don't mind lists. It shows, one, that you're really prepared and, you know, you're organized and you care about your health. It makes your doctor care about your health more if you come prepared. Bring a list of your medications, all that kind of thing is really helpful. And I think it's also really important to make sure that we know if you have any communication needs. So do you need an interpreter? You know, is there something that we can do to help you in the consultation? And finally, I would say, know your rights. So know you're always entitled to a second, third, fourth, fifth opinion. And again, I think people think that, you know, we might be offended by that as doctors, but actually we ask each other for advice all the time. So we're actually very used to it. So feel free to ask. Know that you can complain if you really need to, and know that you are absolutely entitled to high quality healthcare. So make sure that, you know, you get the healthcare that you deserve.
Oh, great. Do you feel that the patients you see in the consultation room understand their rights? You know, do you think they understand the concept of shared decision making, and do they know what to ask for from experience?
That's such a good question. I think some patients do, but I think a lot of them don't as well. And I think, you know, there's a real history of paternalism in medicine. So this belief that because, you know, as doctors, we've done all this medical training, we have all the expertise. So, you know, patients may think that they have to do whatever the doctor tells them. And I think, you know, that's, again, a culture that's been really ingrained, but actually that has changed. And it's really important that we value patients' own expertise in their own bodies. We don't know what's best for you. You know, you are living in your body, but together we can come up with a solution that may help. So putting our knowledge together, I think, will really help. But I think, yeah, I think it is too paternalistic, and people, I hope, will know that they can, you know, share the decision making with their doctors.
Absolutely. And I know my aunt, whenever she goes to any hospital appointments, makes copious notes and writes everything down. And sometimes she gets some strange looks, but that's perfectly her right to do that. And that's really helpful, isn't it? Doctors don't mind, or they shouldn't mind, should they?
No, they shouldn't mind at all. And actually, I think so much happens in a consultation. You know, you may be getting results that you weren't expecting. There may be a management plan. It's actually very difficult to remember. And, you know, writing things down means that you can look it up afterwards, and you can always come back with questions if you have them.
Fantastic. Thank you very much. And Rageshri, we know that health inequalities have affected Black communities living with HIV for many years. And this has been something that I rose for many years. And I remember once talking about it at a conference, and someone said to me, oh, well, that's all a little bit anecdotal. However, I think you really changed things for us when you did some research that really highlighted that people from Black communities with HIV do face worse health outcomes. So thank you for that again. But how significant would you say that systemic racism is a cause of the health inequities that we see in HIV affecting Black communities?
So I think it is the cause. And I think, until far too recently, the medical profession has been educated wrongly, thinking that actually these racial health inequalities are due to genetics. So, differences in bodies between Black people and other people, or due to cultures and behaviors. And we know that just simply isn't true. This is due to systemic racism, and that affects health in several different ways. So first of all, thinking about the social determinants of health. So where we're born, where we live, how we're educated, whether we live in poverty, whether we have access to good food, time to exercise, green spaces, all those things which massively impact our health more than anything else, are affected by systemic racism. So we do know that many Black communities are, for example, more likely to live in poverty, less likely to have good quality housing, etc. And that's what affects their health, and that is what causes these racial health inequalities. Also, we see systemic racism in institutions. So we see institutional racism, and we see that in the NHS, which is an institution like others. We know that outcomes are poorer for Black communities when it comes to health outcomes. And I think that's because of the way the health systems have been designed. So kind of treating everyone the same, not thinking about different needs of different communities. So not really designed in an equitable way. And also we know that people do unfortunately have bad experiences in healthcare and in other governmental institutions, which mean, they face discrimination, they face unequal treatment, and that shouldn't be the case. But that does happen as well. So I think all these things together contribute to those racial health inequalities that we see.
Thank you so much for highlighting that, Rageshri. And I think it is so important that we call out systemic racism. So unless we have these conversations about racism, we're not going to be able to fix it. So thank you for talking about it.
Yeah, I do think that's very important. I think one of the areas that we need to look at is just research around people's experiences in healthcare. I think that's really lacking. There's a gap there. So yeah, something probably to collaborate on community, clinicians and maybe academic organizations. I just wanted to ask, my second question, which was really around the much more practical question around, based on your experience, what you think, where would you like to see doctors do things, differently, so that patients from racially minoritized communities can feel like they're truly being listened to? So maybe your peers, what do they need to do?
I'm doing lots of teaching with lots of healthcare professionals about this. I could talk to you for an hour. So I think it's not just about listening. I think it's about believing our patients as well, isn't it? And making them feel that they've been believed. So, when someone tells you they have symptoms or concerns, making sure that we show that we've heard it by acting on that. So whether that means giving an explanation, referring for an investigation or a treatment, but at least making it clear that we've heard someone's concerns and that we have acted on it. I think everyone should be self-reflective. If you're a healthcare professional, we don't all listen brilliantly all the time. I can't say I've done that. And we really need to think about, when is listening hard? Because listening can be really hard. When is it hard for us? So when are you more likely to be poor at listening? So for me, it's when I'm hungry, it's when I'm tired and stressed. And I think that's also the situations when our unconscious bias comes out. I think we're more likely to kind of rely on kind of stereotypes when we're tired. So being self-reflective, and I think being humble. So kind of understanding that, we're not the experts on everything. We do have medical expertise, but perhaps what our patient is telling us is something we haven't thought about before. Perhaps they have knowledge that we don't have, and perhaps we should listen to that. And, I say to people, we don't have to always agree with everything our patient tells us, but we do have to show that we've heard it and then start a dialogue as to why we don't agree. And hopefully there will be an exchange of information, which means you can come to a shared decision or a shared agreement about something. So I think it's also about, getting used to being uncomfortable. So, I think for change to happen, we have to be a bit uncomfortable, and we don't like doing that at all. So being prepared to listen to uncomfortable truths. But all these things can be hard. So building in within our jobs time for debrief, supervision with teams or with a mentor, I think makes the listening less hard for us. And I do think it is something that people want to change. So that is a good thing.
Wonderful. Thank you so much. And could you tell the audience where they can get hold of this brilliant book?
So Amazon, your favorite online shop, or in some bookshops as well.
Yay! Brilliant. Thank you so much, Rageshri. Thank you. Bye-bye.
Bye.
Bye.
And oh my goodness, that is all we have time for. So thank you everyone so much for joining us.
And thank you, Rebecca and Dr. Rageshri, for coming to the show. You are great, as always. Thank you so much.
And also, I would like to thank Disruptive Live for their technical wizardry in making all of this happen. So do please join us next month for the next episode of Positive Health. It's going to be streamed live on the Phoenix Health Movement YouTube channel, and I have been told to tell you all to please subscribe for updates. So see you then, and thank you so much. Bye-bye.
Bye.
Bye.